Good evening. Today is November 18th, 2020, and it is 5:30 p.m. As a quorum of the board is in attendance, I would like to call to order the meeting of the Central Health Board of Managers. The first item of business is the public communications. Anise, do we have anyone here for public communications this evening?
No, we have no one signed up this evening.
Okay, given that, then we will now proceed to the consent agenda.
Madam Chair, I hate to interrupt. I'm counting and I only get to 4.
Yeah. Oh.
I've got Greenberg, Musaitif, Bell.
Okay.
Laura. I apologize. It's hard when people have their cameras off. I have to scroll through several pages to get
I stand corrected. I will put us on hold.
And there's, as if on cue, there's Manager Valadez. We are ready.
Okay, I thought she was here. Okay.
You can continue.
All right, thank you. Yeah, I did think she was there. Okay. So members, we will proceed to the consent agenda. Item number 1, approve the minutes of the Central Health Board of Managers October 28th, 2020 meeting. Item number 2, receive and ratify Central Health investments for October 2020. Do I have a motion?
So moved.
Manager Zamora, thank you. I'm looking at the squares here. And is there a second? Manager Bell. We have a motion and a second. All in favor? Aye.
Aye.
Opposed, same sign. Any abstaining? Thank you, managers. We will now move to the regular agenda. Managers, we will not be taking up item 8 on our posted agenda this evening, as there is nothing to report on that item. That item was, and I will read it, item number 8 was, receive and discuss the 1115 Medicaid waiver, delivery system reform incentive payment, DSRIP, projects, the Community Care Collaborative, and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas. So we will not be hearing that item tonight because there's nothing new to report. We will now move to the regular agenda. Item number 1, receive a presentation and discuss coordination and collaboration with Community Care Health Centers, Austin Public Health, and Travis County Health and Human Services as on COVID-19 responses. I know that we will have Mike Giesland, Stephanie Hayden, Sherry Fleming, and Jason Fournier presenting. And let me extend a special welcome to Stephanie Hayden and Sherry Fleming, who are taking time out of their extraordinarily busy schedules to join us this evening. Mr. Giesland?
Yes, thank you, Madam Chair. Appreciate that. And members, as you mentioned, I'm joined tonight by Director Stephanie Hayden of Austin Public Health, County Executive Sherry Fleming of Travis County Health and Human Services, and of course, Dr. Fournier from Community Care. So with that, we'll proceed. So as you see here, I'll follow through the slide presentation. Right now, Central Health continues in a remote work environment with limited exceptions. To the extent that you need to come into the office, we can make amends for that. But all operations are functional as a healthcare district, and that includes the joint operations that we share with Community Care and Sendero that are listed there as well. When it comes to what our role is and how we align with the rest of the community, as you're thinking through the subsequent presentations tonight, first I would point out our communications and really focusing on high-risk zip codes, multilingual and culturally affirming and appropriate ways. And Ted and his team have provided a lot of information. Of course, you get the emails and you've seen the videos that Ted's team has produced. And so we've really been stepping up as much as we can to provide support in this area. I would also point out the flu. And while we obviously flu vaccines are administered through clinical partners where people receive their health care, and Austin Public Health has also been providing some flu vaccines. We partner with community groups and Community Care and others when and where we can to help support the flu vaccines, both not only in terms of public awareness, but also at events too, making sure that we've got staff there that can help with either distributing PPE or helping direct, individuals towards where they can receive a flu vaccine, and then obviously providing information as well on the medical access program. So we're going to continue to do this throughout flu season to the greatest extent that we can. Next is contact tracing, and this is where we have partnered in a task force with community care. And it's not just contact tracing for just to determine, who have you come into contact with if you've tested positive at a community care clinic for COVID. We're also taking the opportunity to inform those individuals about resources that are available to them, whether it's for additional follow-up, what to do to protect themselves and their family, about quarantining, et cetera. Next is testing sites. So to the extent that community care has called on us to provide logistic support, there's a number of staff that have contacts within the city and other community organizations to help support community care however we can in the testing sites that were stood up earlier on in this pandemic. And then, of course, which I've already mentioned, the PPE campaign, working with community partnerships, not just government agencies, but other community organizations to be able to distribute PPE. Next slide, please. And last but not least, I'll point out the medical access program. And, in the aforementioned activities that, we've tried to provide support, have provided support, it's important to remember that the medical access program, or MAP, is one of our strongest contributions to this community in terms of providing access to health care for those who are uninsured and below 200% of federal poverty level. And in the midst of providing, continuing management and operation of the medical access program, the eligibility and enrollment services has stood up a call center, along with support from Joint Tech and HR, and that's been an incredible lift in the midst of a pandemic and working remotely. But they have pulled it off and have really incredible results, which you'll hear about in subsequent board meetings. And that's just part of our mission fulfillment. So that's a critical part of our role during this pandemic with respect to the medical access program and connecting with individuals that we're privileged to serve. Now, a couple of commentary as we transition to the other presenters tonight. Healthcare districts have a somewhat undefined role in a public health emergency. A lot of it depends on local planning and efforts, but if you look at 281, it doesn't necessarily spell out really at all about what it is that we're supposed to do in a public health emergency. And so what we did know is that we took our strengths, which you saw on the previous slide and on this slide, and we aligned that with the local emergency operations command, or the emergency operations center, EOC as it's called, because as a fellow government agency, we know this. We take our strengths, we line them up with the emergency operations center, which is where those are coordinated. And we're stronger when we stick together, right? And when we collaborate and pool our resources for the benefit of the safety net population. So next slide. And so with that, I am proud to hand this off to Director Hayden, and she'll hand it off to Sherry Fleming, who will hand it off to Jason Fournier. And let me just say that it has been an absolute privilege and honor to work with all three of these individuals in some capacity or another since this pandemic began. And I'm really proud that we're able to partner together and bring this information to you tonight.
Thank
Director
you.
Hayden.
Thank you. Indeed, it has. Welcome, Director Hayden.
Thank you very much for the opportunity to come this evening. I wanted to just share a little bit of information about, what's happening right now. I thought it would be helpful just to give an overview of just even how we got here. And then I'll touch on just some current plans and distribution, because I'm sure several of you are hearing things about the vaccine as well. Next slide. The department, Austin Public Health, started working on this response at the end of January, early February. We started working with the Centers for Disease Control on monitoring people that were coming back from mainland China. And so at the time, this is not unusual for us. If there is some type of illness, which is communicable in nature, we typically work with the Centers for Disease Control to make sure the patient gets back here to Austin, Travis County, which may be their home. And then we continue to monitor them over whatever the determined amount of time that is established between the state health department and the Centers for Disease Control. And so we started doing that work around that time. Early February, we did open up our department's operations center because we were receiving a significant amount of individuals that were potentially returning that may be affected by this. As we continue to work along and the pandemic made its way to the United States, the city of Austin opened up our Austin Travis County Emergency Operations Center in March. At that time, we knew that from lessons learned, we typically set up with several partners across our community. And it is a joint center between the city of Austin and Travis County, which typically lead the responses in Travis County. However, we have several partners such as Central Health and Community Care that are essential partners for us. We've worked across this community, as Mike Giesland stated. We have our epidemiology and surveillance folks that are continuing to do contact tracing. We have an agreement with Central Health, with Community Care, and UT Dale Medical School. And they are providing contact tracing throughout our community. And so that has really worked very well for us, and we're all continuing to work well. We meet often to talk about cases, etc. We're also partnering with healthcare providers. All of our hospital healthcare leadership team is present at the table, and we're conversations, and we're also sharing data. One of the things that was important for us is we knew we needed to establish a platform. And so we are using a Salesforce platform, which is called Austin Health Force. And that platform allows us to schedule appointments, put all information on there about individuals that are testing, even if the individual doesn't have access to the internet. So we use our medical hotline, which allows us to have people that don't have the internet to call in and to schedule appointments. And so that medical hotline has continued and has evolved over time. Next slide. Thought it would be really important to show some data that I have here. I think did we skip a slide?
I'm not sure why it's just showing as a white screen.
Okay. So essentially, I'll just kind of say what that slide is. That slide shows our hospitalization rate, and it tracks it from early October up until the present. And so currently, as of last week, we have our different populations. You could see how the data, there's been increased hospitalizations in African Americans, as well as the Hispanic population. And so this shows a weekly hospitalization, shows you the number of people that were hospitalized between November 9th through 15th. As you can see at the bottom, it shows you the race and ethnicity. And so we have been tracking that data and have been making that data public um, early on in the response. Next slide. One of the things that we also typically show, and for whatever reason, this one is not showing as well.
Sorry.
This is our.
Perla's gonna pull it up on her computer. Sorry.
Yeah, let's just hold for just a minute, and we'll see if we can
Okay.
rectify this for you, Stephanie.
Okay.
Looks like we're back, right, Perla? Thank you.
Well, I actually, Brianna, are you sharing? Because I'm trying to share and it's not.
Yeah, I just got it back.
Okay. All right, great. All right, Stephanie, where do you want to, which slide do you want?
This is just fine.
Okay, thank you.
Because we can definitely make sure that, I'm sure they will send this out
Of course.
to the membership. So as you can see, we are really are concerned because as you can see, we for several weeks we kind of hovered around 3.8 to 3.9% with positivity in our community. And so right now, as a community, we're at 6.7%. And so we are seeing more hospitalizations. We are averaging about 32, 7-day average is about 32 hospitalizations. And so because those numbers are starting to increase, we are looking at what type of efforts do we want to put in place for our community, because we are very much concerned about the increase in positivity rate. Next slide. One of the things that is very important for all responses, typically, with all of our responses, we always set up a social services branch. The social services branch typically for us leads with equity in mind, but has some kind of primary focuses, so to speak. And so as you can see from this slide, we have been working with some target populations, which we're going to call our priority populations. And we've also made sure that basic needs were met. So we've done some food access, but we've also done behavioral health services, because what we have found during this process is that there have been significant folks that have described increased anxiety, depression, and we also know that during this time, we've seen an increase of domestic violence victims. And so we want to make sure that our social services branch is able to provide those services, and we in being innovative to be able to provide services to vulnerable populations. Next slide. This is a summary of just some of the outreach, financial, and supportive services that we have provided in our community. So whether it is food access to individuals at schools, our homeless population, or doing a larger grant to the Capital Area Food Bank to provide food for larger communities, we've been able to address the inability to access food. Definitely more behavioral health services, but we've worked quite a bit with several partners. Throughout the city, other departments have stepped up and have provided and done some outreach efforts. And a few of our like signature programs, for example, with our website, as far as communication is concerned, we have our dashboards that are there. We have 4 of those there, and we update some of those. We update every evening, and then some like once a week. But it is up to date information that anyone can access by from your desktop or from a mobile device. The other thing is that we've done quite a bit of financial assistance. We established a high-risk workers fund. That fund has a call center line where an individual can reach out and call and say, I have been affected by COVID. I am home. I don't have insurance, or I don't have benefits that will cover my wages. And so we have some nonprofit agencies that are providing that financial assistance and or legal assistance through that program. We have implemented what we've called RISE 1 and RISE 2. Those have been financial assistance programs. And so those financial assistance programs have served over 16,000 households. And so they have provided gift cards, they have paid individuals rent, and they've also provided a resource for them to get food assistance. And then through the Neighborhood Housing and Planning Department, they have their rent initiative. And so over $13 million was allocated to assist individuals with rent. And then Austin Energy had their utility programs that they have put in place, and they have partners that are able to assist. We've done our child care and school support programs, which we have set up incident command areas. So if parents have questions, they can reach out to us either by email or they can give us a call, and we will talk with them about any concerns that they have about COVID-19. And then we've had some targeted efforts, and we've used television and radio to market. We've also done, and we partnered with Community Care and Central Health on our PPE distribution. And so we have provided PPE to the community, but we've also came together on a campaign which was very successful. Next slide. One of the things that we are really sharing with everyone is because there's a lot of concerns about the vaccine and kind of the political nature that has the stigma that's associated with the vaccine. Back in September, these pharmaceutical companies came together and they made a pledge. And so basically the pledge just says that there will be no politics at the table. They will follow all of their standards. They will use be very ethical. They will go through all of their processes They will try to have as much efficacy in the process. They will meet with the FTA for their approval process. So essentially saying, you know, they're not going to take any shortcuts, that they are definitely going to do everything that they can do. As I'm sure most of you have been reading, we have two vaccines that are very promising from Pfizer and Moderna. And so you can go to the next slide. And so as a result of that, myself and Dr. Escott are leading a vaccine distribution coalition. This coalition has several members, and so we meet a couple of times a month. And so ultimately, we are working to develop the plan so we can identify the priority populations and start addressing our messaging and our engagement, hearing from our partners so they can provide input to how we will disseminate the vaccine. What we know about the vaccine, next slide, is that the state has completed a plan in October, and the city of Austin has signed up to be one of the providers. I know most of you may have heard about Operation Warp Speed, and we are a partner in that plan. And so anyone that signs up with the state health services, right now we have about 79 partners throughout Travis County that have signed up to disseminate vaccine. Community Care is definitely one of those partners that has signed up. And so initially within this plan, the plan just basically lays out what would happen at different times. And so right now we're approaching December, and our hope is that there will be limited vaccine. That vaccine is slated for first responders. And we know it's not going to be that much. We don't know how much we will receive, but we are really preparing for phase 2. Phase 2 will allow us to have more doses that will come to Austin and Travis County. And so as we're getting more partners that are enrolled with the Texas Department of State Health Services, we'll have more ways to distribute the vaccine. And then phase 3, we'll see more vaccine will be available. And then phase 4 is October on. We're going to see, you know, it's going to be widely available. So they're anticipating that anyone that would want to receive the vaccine should be able to receive it by October. So as I said earlier, we have our Austin sales force for our vaccine management. And so we're going to continue using the Austin sales force for this vaccine to distribute the vaccine. The vaccines that are going to be available first are they have a two, sorry about that. They are, they have it's 2 doses. So that's why we will have a vaccine management system. And then vaccine that is provided from the health department will be free to the public. Next slide. So that completes my portion of the presentation. And so I believe I was going to shift over to Sherry Fleming.
Yes, thank you, Director Hayden. And thank you for being with us. And Sherry Fleming, thank you for being with us this evening. I know how busy you also are, so I'll proceed with Sherry Fleming.
Thanks so much. And I want to say thank you for having us here. And it's always a pleasure to be here with my partners to talk about the work that we are privileged to do in the community. So just briefly, I'll talk through with you COVID-19 support that the Health and Services Department has been providing. Of course, we are partnered with the Austin Public Health in the response, and most people in this room likely know that Travis County meets its public health responsibilities via interlocal with the city of Austin. So certainly you heard from our leader, but in instances of response, HHS over at Travis County falls in lockstep with Austin Public Health. So we have worked with this co-lead on the social services branch, and that team has done a tremendous job of troubleshooting issues that have arisen, because of course, it would be great if y'all could just address those things that we readily can identify, right? But certainly there are those challenges that are presented, and our team through the social services branch have been stellar in all of the areas that Stephanie displayed. I think it's important also that you know that the county community centers remain open and operational, serving virtually. So I say open because the staff was there, but of course we were not having the community in for obvious reasons during that time. Those staff were able to continue to provide food assistance, utility assistance, food pantries during, and especially in those very early weeks of the COVID response, when of course we know we were challenged by groceries being available and other issues that our community needed support with. In addition, our home visiting programs, while we have not been able to support our families in person, we have continued to support those families virtually, and have also been able to provide tablets so that we improve our interaction virtually with families who need us for support. And those home visiting programs have been able to, in many cases, fill in gaps for families, whether it be because of issues related to supply chain in the grocery stores, or other issues related to their unemployment, or other issues in managing children at home, or whatever was necessary to support our families during this time that we were all grappling with COVID response. Next slide, please. We also had a virtual summer.
Director Fleming, we're having some trouble understanding you. It might help if you turn off your video.
Turn off my video. Okay.
And let's see if that helps with the sound. Sometimes it does.
Okay. Is that sounding a little better?
At the moment, yes. Let's see how that goes.
Okay. So we also were able to conduct during the summer a virtual summer youth employment program. That is another project that we work on with Austin Public Health, and believe it or not, got raving reviews from both the kids and the parents. So definitely some bright spots in our COVID-19 environment. We've also been able to continue to support our seniors through our Coming of Age program. We even held a virtual volunteer appreciation event where we were able to celebrate the many, many volunteers who have supported our nonprofits and other programs in the community. And of course, we've also had an expansion of our basic needs services, and have been able to partner with a relatively new partner in the community around emergency prepared meals. And that also has been a great partnership with the city of Austin through the sustainability group, and in their food access work. Next slide, please. This slide also gives you somewhat of an overview of the CARES Act spending in Travis County. And I will go through it real quickly and talk about some of those programs. Of course, you can see one of the biggest areas of spending was our county direct response. And if you, in that area, you can imagine those are the many, many expenditures that the county had related to just managing the response and preparing for our staff to go virtual. It also has supported our law enforcement and other activities as we have transitioned to our COVID environment. We are also have an allocation for a county joint response, and that of course recognizes our work with the city of Austin. We have invested through HHS in outreach. We have made investments in food distribution, both through the Capital Area Food Bank and the Cook's Nook, which is an innovative emergency prepared food project that we were able to partner early in the response. And as a result of that program, I believe we were able to not only reroute some food that might have gone to waste because our restaurants weren't able to use it, but also employ restaurant and food service personnel. In addition to that, the county has invested in rent and mortgage assistance. We've also invested in a workforce development project that we've been able to partner with the city of Austin on, which provides opportunities for retraining for those personnel in our community who have been most impacted by COVID, and provides the necessary supports to allow them to experience that retraining, and then also support for our child care centers out in the county. We have also distributed over $6 million to small cities within Travis County. We've also allocated funding in a program we call TCTX Serve that I'll tell you a little bit more about in just a minute. But that program just targets our nonprofit community and some of the challenges that they faced in making ends meet under this COVID environment. And then finally, $10 million to small businesses in Travis County through our TCTX Thrive program, which is a program of our Economic Development and Strategic Investments Group. Next slide, please. TCTX Serve is a grant program that we have initiated to provide relief to nonprofit social service providers in response to COVID-19. It's funded by the Coronavirus Relief Fund, CRF. It built on the experience that HHS saw with our Economic Development Group with TCTX Thrive that I just talked about. And we were able to partner with Business and Community Lender of Texas, BCL. And by the time it's all said and done, we potentially hope to support 51 agencies with up to $50,000 in resources that will serve to reimburse them for coronavirus-related expenses that they incurred during the March through December time period related to the COVID response. So these are just a few of the things that Travis County has been doing. And I think my job now is to pass it on to Jason.
Thank you, Director Fleming. Jason, please.
Yes, thank you, Chairperson Greenberg, and good evening, Board of Managers. And so impressive the work that our colleagues at Austin Public Health and Travis County are doing and in support of our community at large. So I just, compliments to Sherry and Stephanie for their steadfast leadership during these most difficult times. Joining me this evening is Community Care's Chief Operating Officer, Yvonne Camarena. I'll ask her to chime in a little bit here, but it's our distinct pleasure to go ahead and provide an update in terms of where we are within Community Care's response to the pandemic and what we've observed. And so we've been fortunate to be able to update the Board of Managers previously. And so some of this will look familiar, but similar to Stephanie and Ms. Hayden, Director Hayden's presentation, I thought, providing where we are currently and relative to where we were and have been, I think is important for the Board of Managers to go ahead and take a look at. And so what you're seeing on this graph really is taking a look at the number of tests that have been returned. And to date, as of this morning, we've provided over 36,500 unique COVID-19 tests within the community, and I'll dive into a little bit more in terms of what we've observed. What we've fortunately have seen over the last 3 months was really a decrease in the overall number of cases. We've also seen a decrease in the number of demand for tests within both our health centers as well as through our drive-through sites. But that's actually not persisted over the last 3 to 4 weeks. We've seen an uptick of testing demand, and that's been coupled actually with an increase in the positivity rate, and really started around October 8th or so is where we started to see a change within the individuals that we were testing. And I do want to premise this by saying what you're seeing and the results that you're seeing really are reflective of just the individuals that we've tested. But what you'll also observe in a slide or two is the fact that disproportionately our tests are directed to individuals who are uninsured within Travis County and lower income is a safe assumption as well. What I'll draw your attention to is that for last week, November 8th through the 12th, so we measure from Saturday to Saturday essentially, or Sunday through Saturday, I should say. We've got, as of yesterday, this was as of yesterday morning, we had almost 64% of our tests back from last week. So our average turnaround time is around 48 hours to 72 hours. And we're working with our reference lab to ensure that persists and have high priority. That stated, we've already been told that the facilities out of Dallas is already at capacity, and they're having to send tests elsewhere within the nation and also to external reference labs. Ours, because of the priority that's provided to us and our population, are going to remain in Dallas and have a commitment for 400 tests a day times 7 days a week in order to go ahead and meet the demands that we're seeing. So we saw within our Latino population for last week a positivity rate of 21.2% and an overall positivity rate of 16.5%. I do want to note that when our tests are coming back early in the week, because we also instituted antigen testing within our health centers, it's used to be in higher positivity, and then over the course of the week as test results return, there's a decrease. So again, this slide was prepared as of yesterday afternoon based on information received back through our systems yesterday morning. I'm pleased to inform the Board of Managers that in the intervening time for results coming back today or overnight and hitting this morning, our overall positivity rate is dropped down to approximately 14% for last week, and our Latino population is at 17.7%. And this is one of those things where you can drive yourself nuts if you're taking a look at the data day in and day out. It's going to oscillate. We're in the midst of a global pandemic and to be expected. So next slide, please. This one here, fully recognize this is about as busy a slide and colorful as we can provide. But this is really one of the things that we're trending internally to better understand what are we seeing in our testing results. And what this is we're building off others that are much more knowledgeable across the nation in terms of different ways to try to understand where the pandemic has been and where is it going. And so one of the things out of the University of Missouri Extension Center, and they've got some incredible mapping capabilities that are tied in with Johns Hopkins, and their platform is called SparkMap. Some are looking at the most recent 14 days of new cases and then making a comparison back to 15 to 28 days. So essentially you're adding up all the cases over the last 14 days, you get a rolling total number, comparing that to what happened 15 to 28 days, and it becomes pretty predictive of where the pandemic is heading. And so I mentioned earlier that as of October 8th, we started to see a rise in cases. What I draw your attention to is what's in green and labeled here are the new cases in the last 14 days. And what's in orange are the cases from 15 to 28 days. And so you can see around October 8th or so, we started to see an increase up. And then towards the beginning of November, there was a little bit of a dip, but proportional to where it was 15 to 28. And then you start seeing a sharp rise. And what's in the blue graph, and it's cut off a little bit for November 12th, is the net new cases 14 days over the last 14 days comparative to 15 to 28. And as of November 12th, for those 14 days comparative back, we saw 73 new cases. So certainly on the rise within the populations we're seeing, and you're seeing an increase getting to, low 20% comparative to where we were 15 to 28 days. I'd also condition the statement based on that this is a rolling average day in and day out. So the percentages are probably not as important as the sheer number of new cases. I'd be paying attention to new cases because that has the propensity then to go ahead and result in increased hospitalizations. The good news based on our partnership with Austin Public Health and information that's flowing from the hospitals, the cases that are at least presenting to date have skewed towards a younger population than where we were earlier in the pandemic as well. Next slide, please. So kind of breaking out who we've served and how we've served folks. So I'm not going to read this line by line. It's really for your reference overall to see, how does this marry up to our overall patient population? What I notice is that the tests that we have provided at community care, as you very well know, earlier in the pandemic, we decided to open up drive-through testing. And we decided also not to restrict that to our own patients. And we also decided to just make it open to anyone who drove up. They didn't have to schedule beforehand or anything like that. Just trying to make sure that testing was available, especially to the communities that we serve, regardless of whether or not they were a patient of community care. So to date, around 40% of, a little less than 40% of all the tests we've provided, of the 36,000 plus, have actually been to community care patients. It's very interesting when we take a look at a map. I think we're now up to 40 states having been tested, but that's a very, very small number of individuals who are coming outside of Travis County. When you start diving into it, and overall you start looking at some of the comparisons, the burden of at least those that we have tested is consistently skewed to a higher burden of COVID-19 within the Latino population. And then when we take a look at it as well, there are some revealing statistics that come out is the burden is much higher when you look at uninsured individuals tested versus insured individuals tested. And you'll see that in the second to last bullet, where you're seeing almost a 7-point difference between uninsured versus insured. And so that also indicates and may be indicative of the fact that uninsured individuals who are employed are also more than likely going to be essential workers that haven't been able to stay home versus someone who has an employer providing insurance. We don't know that for a fact, but these are some conjectures that we're able to go ahead and take a look at. What's most interesting, even though these are drive-through sites, we're very proud of the fact that the vast majority of the tests that have been provided to uninsured individuals and individuals who are Travis County residents. So when we take a look at all the tests that we've provided, 84+% of the Travis County residents, almost 85% of the Travis County residents tested have actually been uninsured. And then on the back end, thanks to funding through the federal government, we're able to recoup some of the cost in providing the tests through the CARES Act. And when we bill out for the services, it's running and being assessed by the federal government to determine if folks are truly uninsured. And so this is a good representation. When someone presents, there isn't a way for us in a drive-through line to be able to demonstrate whether or not they are or are not insured. So we're taking them at their word. 97+% of the individuals who have represented their uninsured turn out to be uninsured once they're scrubbed through the various different systems at the national level. And then remittance of payment for that. And so that's how we've been able to support this. Of course, Central Health, you as a board of managers and Mr. Giesland and staff have been very supportive in supporting our testing initiative throughout. We're also working on FEMA funding to support it as well, but have a commitment also from Central Health to help with that. Overall, 85% of our tests provided have been to uninsured individuals, and almost a 25% positivity rate, or 1 out of 4 individuals testing positive. Next slide, please. So, as many of you are already aware, on the right-hand side is our coronavirus dashboard. It's accessible through our website. You just hit a hyperlink there, and there's a resource hub there as well. And we update this twice a week now. We were doing it daily, but that became a little overkill, right? Especially as we were seeing things fluctuate a little bit. So we update it on Mondays and on Fridays. And we're also participating in getting our data into Austin Public Health Department's regional data consortium of testing to actually make sure that our information is feeding into that. And so you're seeing where it was standing as of yesterday. And the dashboard has a lot of more attributes in it, but we track the last 5 weeks so that community members in that can take a look at this. At the core of what we've done from day one with you as our partners at Central Health and with our partners at Austin Public Health is really keeping a key eye on health equity. We want to make sure that our testing is directed to our zip codes and our community members and patients that we've historically served that have experienced generational racial bias and segregation, and really making sure that we're directing our testing as best we can to the folks who have been marginalized and need to make sure that they have access. As we very well know, they've also been the populations that have suffered more from COVID-19 than anyone else. So that's critically important, not only in our response to date, but also as we move forward. So we're keeping that health equity first and foremost in our minds. I'm going to hand it over to Yvonne to talk a little bit about the next slide, but there's a little image here in the middle. Oh, before you proceed, if you don't mind going ahead and just keeping it there, Yvonne's going to hit on that middle image there and talk a little bit about some of the things that we've been highly successful with, including where we are now with our personal protective equipment. So Yvonne.
Thank you. Yvonne?
Oh, thank you very much. I appreciate the opportunity to speak with everyone this evening to just go over some of the actions that we have taken since the onset of the pandemic. But I do want to echo Jason's thoughts that I think what's been critical in our community is the collaboration between all of our various organizations. And I think that it has really had an important impact to the health and well-being of our community. And as we're going through this next phase of the pandemic, I'm hopeful that that all of these efforts have become more infrastructure and set so that they will continue to serve us well. But we took from the beginning, we understood the importance of listening to what our community needed from us, and they needed information. And so that was really critical, and especially as we're addressing health equity and the disparities that we know our community faces. And so it was really important to us that we started to educate our community about the importance of wearing a mask, about understanding the impact of social distancing, and of course of washing our hands. And so we spent quite a bit of time through our support with Central Health and our internal teams of getting this message out. We have done, we've used both technology and word of mouth as we're providing services at Community Care to offer every opportunity to ensure that our community understood the value of these efforts in helping to secure not only themselves, but their family and the well-being overall of the community. So we could go to the next slide. This also built on other activities that we have implemented throughout the pandemic, and some of these you may be familiar with, but I think they do. It is important to understand how they all layer up in trying to protect our community as much as possible through this pandemic. Obviously, this year the flu vaccine campaign has extraordinarily higher relevance so that we could try to avoid wherever possible the double impact of a COVID virus along with flu. So early on, our pharmacy team did an incredible job along with our participation in the Vaccine for Children program and the Adult Safety Net program to secure 55,000 vaccines for our health centers. In addition to that, we know that there are thousands of individuals who do not have access to healthcare and would not have otherwise access to a flu vaccine. So we did partner with Central Health to ensure that we could reserve an additional 10,000 flu vaccines that we currently have implemented through our drive-through testing centers, where we are offering a vaccine for uninsured residents. And so what we are trying to do wherever possible is that obviously if a patient comes or an individual of the community comes in to visit our testing center and they come in for an asymptomatic COVID test, and we are also offering them the flu vaccine. And you can get both, or you can get one. But we are truly trying to encourage as many of our community to obtain the flu vaccine over the next several weeks. We do see the importance of early registration as far as having an opportunity to support our community with the administration of COVID vaccines. So we have registered all our clinical locations, and we are in the process now of processing our sites through the registry. So we're hoping that will be completed here shortly. And then, as we mentioned before, the PPE distribution campaign, partnering with Austin Public Health and Central Health was key to ensuring that we had effective methods to distribute PPE. And we did that in multiple fashions. We did that obviously through our clinics. It was very well received by our patients as we distributed PPE packets, but we also partnered with Central Health to distribute packets at our testing centers as well. And that was also, we were able to distribute those very quickly, and we know that it was very well received by our community. I think the other piece that was important is that we also provided early on in the pandemic, we wanted to make sure we knew information was power, and that it was critical not only for our community partners, but just our community in general to understand in real time what we were doing to continue to evolve our response to the pandemic. And the weekly updates were the avenue that we used to ensure that we were providing all of the most relevant information, both clinically, also what was happening in our community, and what initiatives were happening at community care to support our patients. And those were, that was quite successful. And it was happening real time. And I think that was what the major value was there. Most recently, we've added antigen testing. And we have this at our community care sites. We use this both for patients who are symptomatic to present, and then we also have this availability at our convenient care sites for patients who are presenting with possible COVID symptoms. And I think the other piece that was critical during this, and we've spoken about it in previous presentations, but the impact of our telehealth initiatives, by our ability to pivot early on in the pandemic to ensure that we continued primary care access was very important for our organization to ensure that we were reaching as many of our patients as possible. And to know that the reduction of access as far as the amount of patients that receive services from community care was only reduced by 5.5%. If you think about this extraordinary year that we have had, we consider that pretty amazing that we were able to maintain our important relationships with our patients, and that we continue to ensure that they had primary care access especially early on and through the first height of the wave in this past summer. So those are just a few items that were initiatives that happened since March. So if you have any questions, I'm happy to support Jason in answering those. And then just one final thing on the last slide, that clearly we could not do this without our staff, and they truly are our heroes. So that final slide that we have, it really is a reflection of the amazing work that's happening by our team at Community Care, and we couldn't be prouder of everything they're doing for us.
Thank you, Yvonne, for all of your hard work and your presentation. Jason, did you want to add anything else?
No, I think Yvonne covered it very, very
Okay.
well. So, yeah.
Okay, I'll turn it back to Mr. Giesland.
Yes. Thank you, Madam Chair, members. So that concludes the prepared presentation, but we are solidly in this next curve of this pandemic with increasing hospitalizations and infection rates and spread. And so what you've seen tonight with the 4 organizations that are at this table presenting to you tonight is a display, and there's so much more that we could talk about. And this is just a fraction of the work and the importance and the impact that these organizations have had in the community that we commonly come together to serve. We're going to continue these partnerships and learning as we go along and re-implementing and making adjustments so that we can together be as impactful as possible. So I appreciate the board's patience tonight. You all have been very kind, and much thanks to our presenters and our leaders here that joined us from the city and the county. And
Well,
thank you.
we want to thank all of our presenters, and we know that there are many, many other people behind the scenes who are working night and day, day and night for months and months. So please extend our heartfelt thanks to anyone and everyone who is involved in helping us to serve those who we are privileged to serve. Thank you so much. Members, do we have any quick questions? Manager Musaita, if I see a hand there.
Yes, thank you. I really appreciate it. I have 2 things. First of all, I want to thank all the presenters for presenting today. Before I ask my question, I have a message to our community, given that our upcoming holidays and where we are right now currently. I urge all of us to take our precaution during this difficult time. I know we are all longing our family, but we are living in unprecedented times, and where we're seeing our numbers are not very promising, and it takes all of us. It takes a village. As we know that we are, the state has the authority, but we have the problem, and our state is not going to take any further actions. And I urge you all to follow the simple, it is simple, but it's very difficult, the fundamental public health
Thank you.
Fundamental public health measures, which are simply as wearing a mask, practicing social distancing, and washing your hands, as simple as that. But this is the time that we all need to rise to the occasion and do it not just for your, do it because you love yourself, you love your family, your community, and you love life, and hopefully all of us can gather around our loved ones at a better time.
Thank you.
Now, my other question is, in terms of the vaccines, I just wanted to know 2 things. Is the city of Austin ready if, let's say, the vaccine was distributed today for them to execute in terms of refrigeration, in terms of logistics? Are we ready to do that? 2, I think equity is an issue that we all agree on addressing. And we know historically, people of color, especially African American, are there are historical gaps in immunization and vaccines. And what are we doing with that specific community to engage them in the trusting this vaccine, especially knowing the history going back to H1N1, how many were reluctant to take the vaccine. So what are the measures are we doing to build trust?
Thank you. I saw that there was a prioritization in one of the slides, so I'm sure our guests can address that.
So I will start there, and I will apologize. Sometimes my camera works for this.
No worries. No worries.
And sometimes it doesn't. So I apologize.
No worries.
So absolutely. I will say yes. We are definitely ready. The department has done several drills. We have a point of distribution plan that we typically follow. We have partners throughout the community which will allow us to use their facilities throughout the city and the county. And so from that perspective, you know, absolutely, I say, yes, we are. We've done a couple of smaller exercises. We did a smaller exercise at our Dove Springs site on the 24th. And we did a larger scale drive-through exercise this month. And for both of those, we used flu, you know, to provide the flu vaccine, but we actually used lessons learned from those two drills just to simulate what we would potentially do in the event the vaccine is ready to distribute. As far as our communications, we did ultimately maybe about a month ago, we put together a flu campaign, and we have because our goal is that we definitely want as many folks to receive their flu vaccines, so we can see an increase in our community. And so we've put together a marketing campaign with some leaders in our community that actually came in and actually received their flu shot and talked about why it was important for us to receive their flu vaccine. And so I think one of the things that's going to be important for us as we start to turn the corner is that we have really with the vaccine, it's going to be important for us to develop the appropriate messaging, and then also have leaders in the community that may be willing to move to a place of, I've had the vaccine, and you know, things are going well with me, etc. And so we're definitely going to be looking at our marketing strategy, getting information out, using non-traditional partners, which we've used during this process, and it has really worked very well. Because, you know, from an equity perspective, we know we are the government, and sometimes folks may not be willing to kind of step up and say, you know, Stephanie, I trust you, but you work for the government. It may come across better for you to work with a grassroots partner. And so, so we have several grassroots partners that we are having discussions with. So it is going to take all of us on board to develop the strategy, the messaging, and it's not going to be a one and done. You know, once we have developed the strategy, we'll have to go back and refine it and make some improvements for that strategy.
Yes, Manager Valadez.
Thank you all. Thank you all for your presentation. But as you know, if anybody has ever read my stuff on Facebook or listened to me do our board meetings, we know that the most impacted population is the Latino population and the non-English speaking population. That's a fact. You can use whatever words you want to use. That's a fact. So to Austin Public Health and to Travis County, Jason, I already know what you and Community Care and Central Health are doing, and I'm very proud of you guys. But to Austin Public Health and to Travis County, this is the first time we've got an opportunity to hear you and to talk to you about the huge gaps in your messaging and in your plan development and implementation and the strategies that you are communicating to the non-English speaking population and to the Latino population. Otherwise, we wouldn't be dying in the amounts and numbers that we're doing. And so, since I know and I'm very proud of the fact that the Austin Latino Coalition early on screamed behind my back, behind me, about care to please make sure you included them in plan development and in implementing strategies, developing those strategies, and communicating to the population that they know best and using the messaging and the words that their population that they know best would be able to respond to, they have not been included. And I know that you all have been meeting, but I also know how those meetings have gone. And so I would like for this to be a reset, Sherry and Stephanie, so that we can all work together, please, to make sure that we don't leave anybody behind. The uninsured population, according to what Jason has told me, is the population that is not accessing resources historically and who we really need to look at, that below 200% FPL. So is there something structurally that you all have committed to that will ensure that all demographic populations are included as representatives in those planning task forces or whatever councils or committees that are being put together, so that we can know that all populations are at the table and representatives are actually included in developing those plans and implementing.
Thank you.
So
Okay.
I really need for a commitment here. If I could ask for.
Okay, Mr. Giesland, let's hear from Mr. Giesland first. He has his hand up. Thank you.
Yes, and just wanted to remind the board that as far as the other government agencies, and to a large extent community care, Central Health is not an oversight body of Austin Public Health or Travis County. Community care, of course, we're aligned with in an enterprise partnership, but even then they have their own separate management structures and board structures. And so, and let me just say, and Manager Valdez, I certainly appreciate your questions. I too have been, I think all of us on this call have been working with the Austin Latinos Coalition, and there's you saw the data, and you've seen the data on the dashboards. But I want to make sure that we're not coming into this conversation with an accusatory tone. It is incredible what all the partners at the table have done to be able to combat this pandemic. And I've seen some numbers recently that if you compare Travis County to other Texas urban counties, we're doing remarkably better. And I think it's because of the partnerships and the strong proactive efforts at this table. I'll let the others speak for themselves, but just in closing, and thank you for recognizing me. Lessons learned along the way, absolutely. I mean, I've had some missteps and some big ones too, with respect to this pandemic, but we all learn and course correct and work together to capitalize on each other's strengths. So thank you for allowing me to make that statement, Madam Chair.
I just clear up one thing right now, because you brought this up, accusatory tone. There's no accusatory tone in what I was asking for. And what I was hoping is that this was a reset button. So please, Sherry and Stephanie, we're counting on you all. You all are the ones that are carrying the ball. And we've got to work with you, and we've got to work together to make sure that every corner of Travis County and every population is covered. With respect to distribution of vaccines, are we going to have representation on the group that's going to be looking at implementation of strategies? As well as, again, continuing to test for COVID testing, to contact trace, et cetera, because we can't drop the ball. We can't let up. We're seeing second spike. So can you please answer that, please?
So I want to start out by saying that the department has worked with various partners throughout this inception. And I understand what you're saying as far as a reset button. But I would say that I don't think that we need to think about a reset button. I think that we have established some really good relationships. And if we did a reset button, we would have those relationships. And so as far as the Vaccine Coalition group is concerned, we do have several community leaders. Paul Saldana is a part of that group, as well as Frank and Lourdes, Carmen. I mean, so I'm just kind of naming a few folks that are that are on that, that are at the table and a part of those conversations. The department has implemented, I think early on, I'll kind of do some back and then kind of come forward, but early on, the department was using task force and strike teams, throughout the process. So we would stand up a team, get feedback from them, maybe implement a plan or put some things in place, get some feedback from them, and then we dismantle that team. And so I think, if we could kind of go back and reset, I would say it would have been important for us to let the elected officials know that if folks were approaching them and saying, how could I plug in? That would have been a great place for us to plug them in. But most of the elected officials in city management were thinking, this is a typical task force through the city, and this is going to have to do the Open Meetings Act and kind of all of those things. And we kind of flagged them and said, no. This is through the EOC. And we've been establishing and having these meetings with different groups throughout the process. And so we do have our task force that meets every other Monday evening for the Hispanic and Latinx community members. They've provided their plan, and they've also provided to us the kind of top 3 initiatives they want us to work with them on, and we've been working with them on that. And so I think as we move forward, those are the things that we're bringing them to the table sooner. And we've said to them, you may think that this may be a painful experience because with the vaccine, we're learning as we're going together. Things may change, but we're bringing everybody along with us with the vaccine. So as we plan and as we start to look at groups to prioritize, we've made that commitment. Even when we look at the financial assistance that we have provided through, RISE 1 and RISE 2, with that 16,000 households that we have provided financial assistance to, which, goes back to April, when we've, kind of started that process of providing financial assistance. Over 75% of the applicants were Hispanic, because, we want to make sure that we are reaching people and meeting people where they are. And so that is our ultimate goal, is that, and we've received feedback to say, hey, let's use the radio station. Here are some radio stations. And, I've had, several conversations, even with community members that have, emailed me or reached out to me, and they're primarily Spanish speaking. And so I'm working with them, and they're talking to me about concerns that they have about, vendors in their community. And so we want to be as accessible as we can be, coming together in non-traditional ways. We did a small contract with Poder because that is one of our communities that we continue to be concerned about, that 4-4 area, with that positivity rate. And so based upon feedback from those surveys, we open up a testing site there. We have a contract with them, and they've been able to survey some folks, do some door-to-door work. So we're continuing to be in that space, providing PPE to them. And so I feel like that we're definitely in a much better place than we were initially.
Thank you so much. Thank you, Director Hayden. We really appreciate your leadership and the creativity that you're showing. We know that you're working closely with everyone, that everyone is working closely together, including with Austin Latino Coalition. I know you're collaborating with them, and so are we. And so I just want to thank you for all of your hard work. Manager Jones, I see you have a hand up. Thank you.
Yes, first of all, I'd like to thank Director Hayden for a great presentation. I'd like to thank Executive Manager Jerry Fleming for one as well as Mr. Jason Fortier. You all are fighting a real battle, and on behalf of the board, we'd like to thank you all for the great work, because this is a very difficult, if not almost impossible battle that we're facing, and you all are doing commendable. I'd like to speak as a board member who believes that you are doing a fantastic job and that you are engaging in it. And I think the message you just gave, Ms. Hayden, speaks specifically to the collaborative efforts that you all are doing in the community. So please do not take the voice of any one person on this board that you are not as gospel. Second of all, you have no obligation, no responsibility to this board. You, as Mr. Giesland had said earlier, have your own responsible governing board. And I'm sure to them you're responding. But we appreciate the time you're taking to come out and share with us what you are doing on behalf of this entire community. The resources that we contribute to make this effort. I certainly thank Mr. Fournier for the effort you've done in terms of what we're doing and the collaboration that both the city and the county are doing in addressing those. As it relates to specifically the data, I'd like to add another time, but you can send it separately, the mortality data in terms of what this this virus has resulted in. I'd be interested in looking at that. Whether one population is 50, 90, or 95% of the population that is impacted by this, we are responsible, the community is responsible for all 100.
That's right.
And so we need to ensure that while we're addressing that disparity that exists in terms of large numbers, that we're not forgetting other communities and the uniquenesses. And I think if you look at the data, we want to make sure that those mortality rates are not necessarily any different or not inconsistent with the morbidity rates that we're seeing, because I'd be interested in looking at. Having said all of that, I just think it's important that we recognize this is a community effort. And whether one community is impacted or the entire community is impacted, we need to work together as an effort to address that. In closing, I'd just like to emphasize that vaccine, as it become distributed to the community, I think, Ms. Hayden, you did a great job in talking about the efforts that's underway. And so anything we can do as a partner to support that effort, I want you to know that as a board member, we will be supportive of your efforts in doing that. And thanks again for the opportunity to share with us this evening, all three of you.
Thank you. We certainly are all in this together to serve the people we are privileged to serve, and we thank all of our presenters tonight for your excellent presentations and your dedication, and we know that you are tired and you have more work to do this evening, so if there's nothing else, is there anything else, managers, before we move on to the next item and let our presenters get back to their other work?
Madam Chair,
yes.
I would be remiss if I didn't answer a question that was asked of me.
Absolutely.
And certainly I appreciate being asked. I think that's what I'm here for, is to respond.
Thank you.
And I won't belabor the point, but I will say that we certainly are very mindful of the concerns that are raised by every member of this community as we all try to navigate this just horrific environment that we find ourselves in. And we continue to work together with APH, and we're interested in working with everybody who wants to work with us. Now, I think the challenge that we all face is maybe when you're ready to work with me, I might be working on something else. But at the end of the day, there's no way for us to move forward without working together. And so if we miss it today, give us an opportunity to get it right tomorrow. And that's why I show up for work every day, for the opportunity to get it right. And so hopefully we will all continue to provide each and every one of us with that grace as we move through this event together. Thank you.
Thank you, Director Fleming. We know how engaged you are with the entire community, and we thank you for that. Anything else? Okay, well then, members, seeing or hearing nothing else from our presenters or from any other board members, we will move on to the next item. But again, I want to thank all of our presenters, Director Hayden, Director Fleming, Jason Fournier, Yvonne, and everyone else who was putting in the hard work for this and continues to, for everything that you do each and every day for our community. We deeply appreciate you, and we appreciate your leadership and your dedication and creativity. Thank you so much.
Thank you for having us. Good night, everyone.
Good night. I know you have other work to get to.
Thank you all.
Thank you so much.
Thank you so much for having us. Have a good night.
You too. We appreciate your time. Thank you. Okay, members, we will now move to item number 2, discuss and take appropriate action on the proposed calendar year 2021 meeting dates for the Central Health Board of Managers. This was included in your packet, and we also had some discussion in the executive committee.
Yes.
Briefly, Per Lukavasas and Brianna Yanes will be presenting, but you did see this in your packet.
Yes. Thank you, Chair Greenberg. Managers, this is a calendar for 2021 of meetings for the Board of Managers, and we put it in your board of packet. Hopefully you've had a chance to look at it. I'm here to answer any questions. If you don't have any questions, we ask for approval from the Board of Managers.
Manager, any questions? Manager Musaitov, do I see your hand?
Yes, thank you. Is the 2 p.m. set in stone? Is there a possibility of moving the Strategic and Planning Committee to an earlier or later time? I noticed it's on a Wednesday, and I personally, I cannot do that. I have a class during that period of time. So because I am on that committee, so is there any possibility of changing? If not, just need probably to reconsider committee assignments.
I will refer that to Manager Bell, who is in fact the, he heads up, he chairs that particular committee. And it might be something that we need to just leave the date there and discuss offline. That might be the most efficient way to do it. But Manager Bell?
I agree. I think we should sort of give it some consideration, but do it offline. It is a issue for achieving a quorum, Manager Musaitov. And so if the majority of the members would, want to move it to a different time, we can do that. But I can't move it if I'm just going to have 2 members, because that doesn't give me a quorum and I can't conduct business.
No, I completely understand. Perhaps a doodle will just assess who's available or not. Well, that's all I just say. Thanks.
We can surely do that.
Yes,
offline.
understood. Understood, and thank you for bringing that attention to our attention, Manager Musaitov. I think if it's okay with him, we'll leave the dates and we'll have some offline means, such as a doodle or other conversations, to see if we can rectify this. Thank you, Manager, for bringing that to our attention, and thank you, Manager Bell. Anyone else? Okay, do we have a motion then?
Sure.
Go ahead. Go ahead, Cynthia.
I was going to ask if you needed to have action then, and if we're going to have an offline conversation, is there any reason to take action? If not, I was ready to make a motion to adopt.
Yeah, I believe it just has the dates on there, doesn't it? Am I correct? So there's no problem. All we have is the dates on there.
It does have some times.
Oh, it
but,
does have some times.
Heading at the top, it says what the times are.
But I believe the motion is for the dates only.
Yeah, the motion is for the dates, is what I'm reading here.
Well, I move that we adopt the calendar as presented by staff.
Is there a second?
I second it.
Okay, so we have a motion by Manager Valdez, a second by Manager Bell. In favor, say aye.
Aye.
Aye. Opposed, same
Aye.
sign. Any abstaining? Thank you, managers. Appreciate
Thank
it.
you.
We'll try to rectify those times, and we can always come back and make changes if we need to, correct, Perla?
Yes, we
Thank you. All right, item number 3, receive an update on the upcoming legislative session and take appropriate action on proposed Central Health Enterprise legislative guiding principles. Again, Perla Cavazos will present along with Marcia Jones from Hillco Partners, who will also present with her.
Yes, thank you, Chair. Managers, given that the next legislative session is only 2 months away, maybe less than 2 months now, we thought it would be appropriate to provide a legislative update. And additionally, in your packet, there are some legislative principles. These are the same principles that have been adopted for the past, I want to say, 4 or 5 years. We did this year add a COVID response item, but we're going to go ahead and begin with a presentation on a legislative update. And I'm going to, before I hand it over to Marcia Jones, I want to just recognize her and her work. We've worked with Marcia Jones, who's a partner at Hillco Partners for many years. She's been our legislative consultant since, I think, the creation of Central Health. And additionally, with her today is Kyle Morrow, who's a policy analyst there at Hillco, who formerly worked for Chairman Richard Raymond, and he was a committee director of Health and Human Services Committee.
Thank you.
So great experience. And also I want to introduce Celso Baez real quick. He's our government relations manager who began working at Central Health in May, and I don't believe we have had an opportunity to introduce him, but he comes to us also with some great local government experience at AISD and Cap Metro. Also on the team helping and supporting during the legislature will be Katie Coburn, David Duncan, and Megan Cermak. I'm going to hand it over to Marcia.
Thank you. Thank you very much.
You bet. Perla, thank you so much for the introduction, and thank you all for the opportunity to visit with you today about where we are and what we expect for the next 140 days following the second Tuesday in January. And just know that the crystal ball changes, so we may come back to you and say, well, what we thought would happen does in fact change. And Chair Greenberg, it's always intimidating to present in front of you because you have been such a trailblazer, not only for women, but for policy and healthcare policy and for leadership in the state. So again, always great to see you. And
well, thank you, but I would say that goes for our entire board. Thank you.
Well, I would agree with that because I know many of these faces I have seen at the Capitol and I know are very, very active locally making a change. I do want to echo what Perla said about the expansion of the team. You probably, for those of you who have been in politics a long time, will remember and recognize Kyle Morrow as a political dynasty name in Texas, and we are so proud to have Kyle and to have an individual of his caliber who was interested to devoting really his political career and his policy career and his advocacy career to healthcare because there's so much to accomplish. So with that, let me very quickly walk through these slides and we'll get to questions and as Perla said, the action for the evening. Texas voter turnout, this is really, I think the shocking part of this is how much money came into Texas to turn Texas into being a more competitive state for Democrats and for perhaps being purple. And that was really not the outcome. You see that the numbers here are basically what represented the last presidential election. Although the upside is there are significantly higher numbers of raw votes on the Democrat side versus the Republican side. And that represents gains in a lot of areas, but especially in young voters and diversity of voters. And so that is something to be proud of, regardless of what your viewpoint is politically. Next slide, please.
Do we need to share a screen?
Yeah, 1 second. It's doing it again.
I understand. We've had a lot of issues with both audio and video this evening. I think too many people are trying to use everything. Internet instability.
Well, while we're waiting, I can continue on if.
What? Oh,
there we are.
I went ahead and shared.
Okay, thank you.
All right, next slide from that one. The one comment about the Senate that I would make, actually there's two. First, there is one flip in the Senate from San Antonio, where former House member Roland Gutierrez will replace Republican Pete Flores. And so there is a net gain on the Democrat side, meaning that the Senate will have to again change their presiding rules of suspending the regular order of business in order to bring up legislation. It has been at 21, and as the Republicans have lost ground in the Senate, that parliamentary threshold has been changed. If there is not agreement to do that, it means that we might revert back, and I say might because I think it would be an incredibly good thing, where Republicans and Democrats in the Senate have to talk to each other, have to work together in order to get their votes either over 18 or back to 21 and in order to debate legislation. So watch for that. That could be significant. Next slide, please. On the House side, while there was so much hope about changes that could occur in the makeup of the House and what that could mean for some healthcare issues, the reality and the net of it is that we ended up in exactly the same place where we started, and that is we had one Republican seat that switched to Democrat, and we had one Democrat seat that switched back to Republican. And they're both in the Houston area. Unfortunately, we did lose Sarah Davis, who is a really, really effective healthcare advocate. And so the House, once again, will be unknown as to the healthcare leadership, because Sarah was really the anchor this last time around and will not be there this time. Next slide. Speaker's race, I think you've all heard about Dade Phelan. And he continues the pattern or historic, just what has been traditionally the case, that a speaker who is really going to be viable has the votes a couple of days after election. Well, that wasn't really expected this time. Dade Phelan came through. He is a former staffer from the Senate that Perla and I have both known for quite some time. Started as a staffer and worked through college, did both state and federal level politics, and then went back home to start a family and does investment business. He was brought to power by a coalition that included some leadership from Donna Howard, bringing a number of Democrat women along, which I think foretells well for some women's healthcare issues, which she is the caucus of this time, and helped get Dade Phelan over the threshold that he needed in order to secure his speakership. So you see that we have a young man with a young family that is behind him, and somebody who knows his way around the Capitol. And that's what I just told you. So next slide. But I will, one thing that is very curious, I will say that he's worked for one of the nicest people in the Senate and one of the most, and Chair Greenberg, I don't know if you served with Mark Stiles, I think you probably did. but one of the toughest. And so he has some real political chops. And he begins his 4th term in January, which means that he hasn't even served 8 years yet, and he's already speaker. So it does tell you what kind of respect he has from his fellow House members. Next slide. So a look at session. That is probably the most significant component that will determine what happens. And most of that driven by how much public access will be at the Capitol, because what happens at the Capitol is really only as good as those who are willing to be involved. And if you can't get in the building, well, then that certainly limits your ability to participate. You have a pretty significant chasm between the 2 chambers, between the Senate and the House. The Lieutenant Governor was in our office just recently talking about how he wants to limit how many bills senators can pass or bring to the floor. So we'll see how successful he is in that capacity. The House is on a much different program. They want to have safety protocols that allow people in the building, but there are some limitations just logistically and by space, which again may create some bottlenecks. So the speaker, Speaker Speaker-elect Phelan, does have a group of members that are looking at how to safely open the Capitol and do the people's business. So that is to be determined. But who is in the building, how often they're in the building, and whether there are any kind of predisposed limitations may significantly impact what happens this session, more so than the issues themselves. Next slide. So legislative priorities, as in all things, you can only have policies that you can pay for. And while policies to drive the budget drives the policy, we have a significant shortfall, although we do have a significant rainy day fund that I do think will be used. The budget situation also creates an opportunity to talk about the increased FMAP that exists in the Medicaid program that is helping to minimize some of the shortfalls. And even when you talk about that return on investment, you do have some issues when you're talking about Medicaid policy, but nonetheless, the reality is healthcare is saving the bacon of the state right now to not have a more significant financial problem than they do today, and it's getting better as time goes by. Redistricting, of course, everyone talks about redistricting affecting the cadence of the session. That isn't really true. It affects who's mad at one another and explains why you might vote one way or another where it doesn't make sense. But redistricting data is not expected until July, and so while there'll be quite a bit of conversation about that and it will create tension, it really is a non-issue during the regular session, unless something changes again, but we don't expect that. And then legislative priorities, just like your discussion to start off the meeting, one of the few things that the legislature has to do is pass a budget, and it has to address COVID response. And Hurricane Harvey created a blueprint for that, where there was a report from Texas A&M, because Nim Kidd, the head of the TDEM, Texas Department of Emergency Management, is also affiliated with Texas A&M, and Chancellor Sharp has had a significant role with the governor on the economic impact as well as the healthcare policies that should be pursued. There will be a report that comes out with recommendations about COVID response and about legislative actions that need to occur. And as we have rightfully so spent a lot of action and a lot of investment in the community this time around, it will be an opportunity for I think Central Health and for the FQHCs to again talk about how funding for them is important, to discuss the proper place in emergency response, and then for us to perhaps be able to come out of the legislature with some best practices on infectious disease, as well as increase the opportunity for telemedicine to be a continued platform that has even more opportunity to transform healthcare access. So next slide. Medicaid expansion, I know that that is a topic that is, I've heard more chatter about Medicaid expansion from Republicans and Democrats than I ever have before. The upside is that the conversation is happening. The upside is that privately, the governor will say in meetings, he recognizes there is a coverage gap, especially in the context of COVID, where it's safe for him to talk about that, where commercial insurance has been lost by families that not normally would be in that situation, but that there still remains a significant gap in low income access to health care. And there have been some Republicans on the House side talking about Medicaid expansion, especially in context of thinking that there would be much closer vote totals between Republicans and Democrats, or potentially even a Democrat House that would drive the issue. And as we visited before, that is politically not the case. So then how do you make a financial case? And we talked about the budget. We talked about there being multiple studies on the return on investment of this being financially something that makes sense, but I don't see full-fledged Medicaid expansion happening. I think that you may see some expanded benefits for, say, postpartum, which is helpful to central health, but certainly not the the full coverage that we need. And I think that you could also have some mental health expansions. And some good conversation, but at least what is likely to happen on coverage will be around eligibility time periods, and perhaps some expanded benefits or expanded Medicaid coverage to certain kinds of populations, especially like pregnant women and maybe even some kids things. So next slide. Was that it? Well, whether it was or it wasn't, I'm done.
Thank you. Okay.
So in closing,
yes.
So in closing, what I do believe is that for one of the first times ever, healthcare will be one of the most important things that the legislature talks about. There will be lots of discussion about it. I do believe in some areas that we will be able to make up decades of the lack of action. And in others, we will have some good conversation and perhaps be in the same place at the end of the day. But it is significant that healthcare is one of the only things that has to happen during session, and that is important, and that is an opportunity for us, and look forward to working on your behalf.
Indeed, it is an opportunity. Usually it's the budget, because it's the essence of public policy, but I think we can say the budget and healthcare. Yes. Perla, where do we go from here in this presentation? Thank you so much, Marcia.
My pleasure.
From here, I would like to ask if the Board of Managers would approve the legislative principles that were in your packet. I can have Brianna pull them up if you like.
Let's pull them up. Let's pull them up quickly where people can see them, and then if we can get a motion.
Yes. And managers, these are the same principles that we've adopted for the past several years. These are the issues that we will be monitoring during the legislative session. What's new on here is the first bullet, which is a COVID-19 response, and ensuring that our local health systems have the resources needed to respond to the pandemic.
Thank you.
That's it.
Okay, members, do I have a motion? I'm looking.
I have a question.
Oh, certainly. Question? Yes.
Marcia, thank you for that. I know both of you, all of y'all, is working real hard on this. With respect to health information technology, that little line, I was wondering if you could add health information and technology and healthcare literacy, or health literacy. Because there we could go not only into the healthcare component, but into the educational component, and ask that healthcare literacy be taught in pre-K up 12, grade 12 in public education as a part of their curriculum. And this is in reaching out into our communities and our families that don't have that at the table. And I know so many families that have their kids go with them to they don't understand what's going on. If they have a child that's referred to special education, they don't understand any of that. And what we need is a basic understanding of what health literacy is. And I ask that you could include that in that little section.
And Manager Valadez, Valadez, I would probably say that might fit more nicely into the prevention and wellness.
Wherever it wants to go. I just think that health literacy is an important.
Okay.
I understand. Yes.
Okay.
I agree.
With respect to
Manager Valdez, you may want to turn off your video. Your voice is fading in and out. See if that helps.
Okay. Let me turn off the video. There you go. And also with respect to down here where you say population health.
Yes.
In where is it? I guess in the middle under healthcare innovations. When you advance population health, I would like clarification, Marcia or David, whoever our attorney is. If it's my understanding, and I've many times, and I want to make sure that that I'm not misinformed. We were created under 281 to provide healthcare, access to healthcare and hospital services for the indigent, for the uninsured, and the working poor. That's our targeted population. And the way it was explained to me, someone at the Capitol, when a healthcare district was created, then what that did is put population health in the arms of the governmental entities, and the healthcare districts took over the provision of supports to the targeted population, which is again uninsured, indigent, and working poor.
Okay, does somebody want to address this?
For somebody to put advanced population health, that's the role of the governments, the cities and the counties, not the healthcare districts.
Thank you, Manager.
I can address that. Manager Valadez, really, this is legislation that we are, tracking. There, it's broad, fairly broad language. We do track, public health issues, population health, social determinants of health, because if there's a way to improve those factors, those variables, really, that's going to lead to better healthcare outcomes and, make our work hopefully easier. So
Pedla,
yes.
I just want clarification here. We support the counties and the governmental entities and providing that, okay? Because we're a partner with them.
Manager Valadez?
I just wanted to understand why somebody's including that here. Except outside that realm. In general terms, is that what it is? It's just a general term?
Really, these are just, broad issues that we're going to be monitoring.
Got it. So in light of that, Madam Chair, I'd go ahead and make a motion that we just go ahead and adopt the guiding principles for those.
I think Manager Musaitov had something else. I see her hand up. And if anybody else does, I don't see your hand, just shout out, please.
Okay, well, I'm putting the motion forward. I'm putting the motion forward.
Well, okay.
You can take a motion at any time.
I'm sorry, you were cutting out.
Yeah, I said you can take a motion at any time. Making a motion, there's a second.
Okay, Manager Musaitov, did you have anything to add?
Yes, within at our Texas Public Health Coalition, we set up our priorities for this year. And one of them, obviously, I think you alluded to in your slides, the 5% reduction in health and human services. And that will definitely hurt us. And when I saw some of the programs that they are planning to unfund, I feel it will disproportionately impact our communities, especially our underserved. So I was asking, is there a possibility to us to advocate or any kind of language to not to restore the 5% reduction in the services? So just something that it's one of our priorities with our coalition. I was hoping if we can add this to ours as well. If not, that's perfectly fine. Thank you.
Thank you, Manager. Does somebody want to address that?
Marcia, do you have any thoughts on what, if anything, we could do in that respect?
Sure. I think even under reimbursement rates, Perla, we could say defend against budget cuts that impact our services, our community, our operations, or our budget. So then it's pretty broad because
right.
Yeah, I see that, and I can also see how healthcare financing is also fairly broad, that bullet point.
Right.
I mean, one of the main issues that we track is funding and any opportunities to protect funding for healthcare and increase funding. So now that I'm looking at, the rates, but also the healthcare financing bullet, I think that would fit as part of that. I mean, we could draft maybe some more specific language or include some more specific language about discouraging agency cuts, but I feel that bullet is fairly broad.
Okay.
Chair?
Yes, Manager Jones, is that you? Yes.
Yes, I just have a quick question. I agree with all of what's outlined here in terms of guiding principle. I don't see, and perhaps is embedded in the healthcare financing, is the support for vulnerable population, but addressing the issues of disparity in the population. Is there a guiding principle where we speak to that?
Yes.
Carola?
Right, and Brianna, if you scroll to the next page, there is one bullet that fell off, and this may not necessarily get to it, but I think that's a fair point, Manager Jones. In this bullet point, we tried to talk about ensuring a workforce that is diverse and culturally competent to reflect our diverse community. But scroll back up, Brianna.
Well, mine went more to the fact of particularly
equity.
In a pandemic year,
Okay,
where we talked about the COVID response. It just seems to me a void of mentioning populations of color anywhere in our guiding principle. And I don't know if that needs to be a separate bullet or embedded and implied in what we're saying here somehow or the other.
Thank you, Manager Jones. That's another important point. And
right.
Carol, I'm wondering if it needs to be.
I think that could be a separate.
I think a separate bullet, I say, because I don't think we want it just confined to the COVID-19. So maybe a separate bullet just addressing health equity and health disparities.
Yes, I think that would be very helpful.
Okay. Manager, shout out. I'm looking and I'm not seeing or hearing anyone else who had.
Manager Valadez has her hand up.
She does. Okay. Thank you, Manager Valadez.
Yes, and Manager Jones is exactly right. The closing of disparities gaps. That's very
right. We're drafting something for that. Okay.
The closing disparities gaps, because it's not only for people of color, but it's people who don't speak the language.
Right. Right.
It's all encompassing.
Right. That's why I was using the language of health equity and health disparities, not any particular group, but that general language of health equity and health disparities. Right. To be.
We will work on some language for that.
Okay. Does anybody else have anything to add?
You achieve health equity by closing disparities gaps for all populations.
Anyone else? Okay, I'm not scanning. I'm not seeing any hands or hearing anything. Members, I would ask this, maybe Perla, if you could just, there were, I think, I was trying to count maybe 3
Right,
items
3.
that were mentioned, and thank you, members, for that. If we could maybe have some kind of motion that says we'll adopt it, incorporating the language, and I think we can press that they're working on the language that we talked about. Members, would that work?
Yes.
Do I have a motion?
I move that we adopt the guiding principles for the upcoming legislative session as recommended and modified.
Okay. Is there a second?
I second.
Okay, so we have a motion from Manager Valadez, a second from Manager Jones. All in favor say aye. Aye. Opposed, same sign. Any abstaining? Thank you, members. That was a great conversation and some really important points and additions that will get wordsmithed according to your direction. Thank you so much.
Thank you, managers.
Thank you. Thank you for presenting, Marcia. And I think Kyle was with you, right?
He was, indeed.
Thank you so much. All right. Thank you all.
Be well.
Good night.
Good night.
Okay, members, we will now move to item number 4 on our agenda. Receive and discuss the following focus reports related to the strategic objective in section 2.1- well, I think II 1-B of the resolution adopting the fiscal year 2021 budget. A, current workforce demographics and levels, including new hires and turnover. B, enterprise EEOC category reports and demographic background. And C, compensation report. And Susan Willers will be presenting. I think she has a brief presentation for us.
Yes, thank you. Thank you very much. Good evening. I'm glad to see everybody. And I know that we were aiming for an early time today, so I will be concise. On the memo that you all received, I'm listing on the left-hand side of the memo the data that we shared with you in 2020. And we're introducing to you a new format for fiscal year 2021. And this is really, what we did is we, and I say we, but really Betsy Good is the master behind all of this great work. But because in October we hit a year of presenting this data to you all, we decided to assess the information and really determine how much more data can we share with you and how can we deliver it in a format that's concise and short versus the 10 to 15 PowerPoint slides you were getting every quarter. So I hope that you agree that these dashboards are pretty effective, and we're sharing a lot more data with you enterprise-wide and also Central Health proper. So with that, I'm just gonna give you a quick review. And I wanted to make sure this was large enough for everybody to see, but this is dashboard 1, and this is the headcount demographics. And so this will give you tonight we're presenting the fiscal year 2020, but starting in January, we're gonna be sharing the fiscal year 2021 every quarter. So this really closes out the fiscal year 2020. So the headcount demographics, this is enterprise-wide. And then it gives you the headcount by entity, the male and female ratio by entity, the tenure by entity as well. And then we're sharing with you generational information by entity. So that's dashboard number 1. Dashboard number 2 is going to give you the turnover report in a different, we're sharing a lot more data with you than previously. We're comparing the fiscal year 2019 or to 2020. This is enterprise voluntary turnover, and this is the Central Health voluntary turnover. And here you'll see the other 2 entities for the 2020 year, their turnover broken down by quarter. This will give you the enterprise voluntary turnover reasons, and then this is Central Health proper. We're also sharing with you the tenure of exiting employees. So every quarter you all will be able to see that data. The third dashboard is what we're calling the diversity dashboard. And so we're going to be sharing with you gender identity distribution, hires by gender, and then terminations by gender. And again, this is just a wrap up for 2020. This is the racial ethnic distribution as a whole. And then the hires in 2020, their distribution, terminations. And then of course, you've asked for us to include populations served by race and ethnicity. So we will be including this from, I think from the previous presentation on forward. And then the last dashboard is really our diversity EEO4 distribution. This is a little difficult to see. The last presentation that we, Betsy and I presented, we presented on the EEO4 and shared with you in your packet a lot of data on EEO4, the categories and the definitions. I failed to include it in this presentation, but we can certainly send it to you so that you have it handy as you look at this data. But what this does is the EEO4 data that we have to report every other year to the EEOC falls under admin support, officials and administrators, paraprofessionals, professionals, and technicians. And they provide definitions, so we have to plug based on people's roles where they belong. And so this line right here will show you this is where between this line and this line is your admin support. This line and this line is your officials and administrators. Here we only have the category of white for the paraprofessionals, and professionals is from this line to this line. I just wanted to give you an orientation on how to read that. And then Betsy took it a step further and provided so this is the overall EEO4 for Central Health. This is the new hires EEO4, and then of course the turnover by EEO4 data as well. So I know I went through that very quickly, but we're really hoping that you all will enjoy the new format from this point forward. We think it offers you a lot more data and it's a little cleaner.
Thank you, Susan. And thank you, Betsy. I saw you on here. I know that this was a lot of hard work and we appreciate it. And the board had asked for more detail, and we appreciate you providing it and providing these dashboards. Members, do we have any questions? I see Manager Valdez and then Manager Jones.
Susan, thank you much for I like the graphs. With respect to this EEO graph that the data that we submit to the EEOC, I'm assuming, yes. Is there a way for us to where are the supervisors, the executives? Where is that? Are they in the officials and administrators section?
Yes, and I think that list of categories that I included in, I think it was the October packet, I can go ahead and resubmit that so that you can look at all those titles and figure out where people are plugged in. Yeah.
Okay.
If you could send that to everybody, that would be helpful.
Yes,
sure
please.
Will.
And one last question. What does job abandonment mean?
That means that
never heard from again?
That means that somebody just was a no call, no show. They didn't actually walk off the job per se, although that does happen sometimes as well. But in this case, it was individuals that just didn't call or show up to work the next day and then never showed up to work after that either.
Okay, and that's per entity.
That's per entity. That's
Thank you very much. Thank you, Susan.
Thank you. Manager Jones, I know you had your hand up.
Yeah, just two quick comments. One is, this is excellent. I really appreciate it. This is very visible, very clear, and very usable. The second comment is that I'm part of the baby boomers in that first list. So is it possible that you all could print this out for us once a quarter so that we could pick it up? I've used quite a lot of paper here at my house, and trying to see this for a baby boomer is difficult for me to read sometimes.
Absolutely.
So if you could print it, have it available, I would very much appreciate it. But this is excellent in terms of helping to get the picture that I was trying to look at. So thank you so very much for doing this too.
You are welcome.
Thank you, Manager Jones, and understood. I'm sure anybody who needs it printed out quarterly, just let staff know. Thank you. Any other questions? Again, I'm scanning, looking for hands, trying to hear voices. I'm not seeing anyone, so if I'm missing you, please shout out. Okay, if not, then I don't think there's any action necessary on this. So thank you very much, Susan and Betsy, for your hard work. We'll look for that additional information that you're going to send. And Manager Jones and others who need something printed, please, probably the best thing to do would be to contact Brianna, right? And she'll arrange that for you.
Yes, thank you.
Thank you. All right.
And Manager Greenberg, I do have one other piece.
Thank you.
On the
Okay.
compensation.
Yes, you're right. Thank you for reminding me.
Sure. And so this evening, we wanted to provide you with some updates regarding the recent changes that were made to our compensation program, really within the last 6 to 7 months. The Central Health, just as a reminder, the Central Health Enterprise minimum wage changed from $13.64 to $15.04 in the spring of 2020. The new compensation software was purchased in September, and Betsy is now an expert and is working her magic with that software. The software is going to allow us to automate and price jobs to multiple survey sources automatically. It will also allow us to analyze the data and run equity studies on gender, race, and ethnicity. And so the third thing that just happened last month was the revision to the compensation philosophy. So those were huge changes to our compensation program. The enclosed documents, which are these documents here, this looks a little familiar. This is the second year we share this with you. And so these documents include the review of salary grades per structure. Each grade contains the average salaries and average years of experience based on gender, race, and ethnicity. We wanted to make sure to include this in this presentation because part of the board matrix, the cadence requires us that, to present to you during this month. So I wanted to make sure we adhere to that. But what I would like to ask you is to allow us to come back in January after we implement our new philosophy and create the work on the study, and then also run the equity analysis and come back and present this data to you again.
Thank you. Delighted with the increase in minimum wage and with this new software. And thank you, Betsy, for becoming the guru on it soon. And this sounds very reasonable to come back in January when you can run it through the equity lens with the new software. Managers, any questions?
I have one, Sherry.
Yes, please. I think that was Manager Oliver I heard. Yes, please.
So I think you mentioned that the minimum wage was enterprise-wide, so that includes community care as well?
Yes, ma'am. Mm-hmm.
And I know when we talked about that before, there was talk of perhaps like lifting people up to a minimum wage of $15, but then freezing it for like 3 years. That's not part of this, right?
I'm sorry, what was the last part of that?
I said is that policy adopted or not adopted? Because I don't think that we were in favor of that as a policy, to freeze wages at $15 an hour for like 3 years.
So the minimum wage.
That conversation that we had earlier this year is probably at the end of last year when we talked, and community care was not at $15 an hour for minimum wage.
Correct.
And y'all proposed, well, we could lift people up, but then because we didn't want to adjust all the other pay grades, we could just freeze somebody there for 3 years. And I was like, well,
yes, no, yeah, no, thank you. Yes, I do remember that. So what we're doing with community care is every fall, which is right now, we conduct our market study. And so the idea was that we would raise everybody to minimum wage and then look at any equity issues that caused to fix them during the market review process, which is exactly what will happen between now and December 18th, I think.
So when you come back in January, you'll be able to discuss that with us, right?
Yes.
Okay.
And I just want to make sure that we weren't adopting this freeze for like 3 years, because I don't think anybody wants to live with pay freeze for 3 years.
No, I think, and I remember that the impact, if we moved everybody accordingly, it was going to cause this huge financial impact, but that was not the case. We did not do that. And now we just have to work on the equity issues.
Okay, so just to clarify things, okay? The increase was encompassed not just central health, but also community care. And there was no freeze for 3 years. Is that correct, Susan?
That is correct.
Thank you. I think Manager Oliver, does that address your questions?
It does indeed. Thank you.
Thank you. Thank you so much. Anyone else have any questions? I'm looking. Okay, I'm not seeing or hearing any, and I don't think that we will need any more. We don't need a motion on this. My understanding is that Susan and Betsy will continue to work on this. They will do the market study. They will use the equity software, and they will come back in January and report again. Is that correct?
Yes, that's correct.
All right. Thank you very much. Okay,
Thank you.
We will move to item number 5, receive and discuss an update on the EPIC electronic medical record system implementation. And John, I think John Clark has a brief presentation for us. Is that correct?
I do. Thank you. Thank you to the board for having me. It's been so long since I've been able to see you guys. I miss every one of y'all, and thank you for having me tonight. I know that we're on a tight timeline, so I'm going to really kind of move through this quickly, and I only have a few slides, so hopefully we can get through it quick. It is amazing to me that we are where we're at right now with this EPIC install. Many of you know that we've been talking about this for well over 2 years, and here we are. We're right on the cusp of getting it done. And I am just thrilled to be able to bring this presentation and update you on our progress. So the EPIC, so in the third quarter and fourth quarter of 2019, the selection was made to move forward with EPIC, and the project actually kicked off January of 2020. That kickoff included a trip of many leaders and staff from Joint Tech, as well as the community care folks, to Madison, Wisconsin, where EPIC is located. And in that, they were able to learn about how the actual project was going to run and get very familiar with the process that EPIC uses. EPIC also had several folks come directly to community care and go through some guiding principles and some goals to outline how the project would run. And the essence of that is that this is really a multifaceted, resource intense project that really needed to be driven from the users of the system, which in fact is community care. So the work really began on the project in February of 2020. And since then, there has been a ton of work being done. So go ahead to the next slide. So where you see the little "We Are Here" line at the top, that is actually our progress thus far. So we're currently in the user and system readiness phase of the project. Testing of the system build is underway. We are in the process of prepping and deploying equipment. So I'm sure that a couple months ago, there was a request from the board to include equipment for the exam room technology. And this is part of the work that we're doing, and also replacing devices that are no longer sufficient or will not sufficiently work with Epic. There are also third-party application interfaces and integration testing going on, and we're testing out all of the data conversion files from the next-gen system. So go ahead to the next slide. A big portion of what we're planning right now is our training. And in effect, we've already started. So the training registration of the staff began in October. The pilot training is already underway and is taking place currently. This is where several key individuals who will be helping to navigate the training going forward are actually going through the training program. And then planning out how the future of that training will look for the staff. So currently working at many physical locations to identify training space. And we're going to be utilizing most of the conference rooms across the enterprise, including some there at the Chancellor Building, as well as many locations at the community care administrative offices. So logistics and planning around the hardware necessary for training are underway. So much of the equipment that we will need to deploy out to the exam rooms and to the various locations clinically, we're going to need to actually have set up as training devices. This way we're not overbuying equipment, and we are able to then redeploy that equipment for the actual use of the system. There's still a lot of effort to find additional resources at CUC to act as credentialed trainers. And that is folks that are actually going to be with us for the duration of the project and go back to their normal jobs after, after the training is done. But they provide some synergy and some longevity for us going into the future. Just to highlight, the end user training will actually begin in February. It's actually going to be the first week of February. So we are getting there quick, and we are really looking forward to that training. Go ahead to the next slide. So there have been some challenges and things that we've had to mitigate along the way, and this is a representation of those. In no way is this all of them. These projects for EMR and practice management solutions are very, very big, and they come with a lot of challenges. But I wanted to point out a few of them. So early on in the project, the decisions around staffing and certified staff on the build for the build elements, it took a long time to make decisions around how that staffing was going to be appropriated. And so we actually got through that, and the team is fully staffed right now with the exception of a couple of the training resources that are being hired currently. And the third-party application contracting, this is an area where community care has been heavily involved. These are tools that they absolutely will need for their clinical operations that we need for integrating into the EMR. And so with this, most of the third-party applications have now been contracted. There are still a couple of them that are outstanding. Community care is well aware of those and is working very diligently to make sure that they get those under contract. And the project team has made necessary adjustments to prevent delays. There have been a few unanticipated changes to the project scope. As I was mentioning before, the EMR or the exam room technologies were not included in the original scope of the project. It was something that we thought to do later after we actually went live. This became something that the clinicians as well as administration at community care were very, they were very adamant that we would move forward with this at the go live. So this was a change in scope. Additional interfaces in some cases were added that we were not planning for. So the main point here is that when changes happen to the scope of a project, it makes everything kind of trickle down, right? And so you're scrambling to try to figure out how to keep on the same timeline and to still make the outcomes that we're looking for. So we've been able to do that for the most case. I think that we were originally thinking that we would go live at the first part of March, but we're pushed off to the second week of March, or the third week of March. So if you want to go to the next slide. So our anticipated go live is actually March 27th. So again, it seems like it's still several months away, but it is right here and coming quickly. And also just to let you know, the work really doesn't necessarily stop after the go live date. There will be a lot of things happening, tweaking the systems, as well as there's other tools like the pharmaceutical system and other things that we are not planning to implement as part of the first phase, but we'll be actively implementing after this go live date. So I think that is it. If there are any questions.
Well, thank you so much. This is just wonderful. And we appreciate the hard work of you and your team and all the others who are helping on this and doing the training. And I'm certainly aware of the age-old problem of change orders and what that can mean as far as trying to keep on schedule. But that's very exciting for the go live date later in March. Anybody have a question? That we don't need any action on this item. So before we move on, is there a quick question, Manager Valdez?
We're very quick. John, thank you, and I'm glad you're finally getting it in place. With the change in project scope, have you seen any change in the budget, or are we going to be able to accommodate everything that community care and central health needs, that our enterprise system needs for the lifespan of implementation of this project? Are we going to be okay, is what I'm asking.
John?
Yeah, so I think that there have been at least one time where community care as well as others have come and presented back to the board some necessary adjustments to the original funding. But as far as where we stand right now, we are still on track with that budget. I know that there are many things that community care is doing in addition to some of the original funding for the project on their end to accommodate things like contractors and different things of that nature that are needed to get us where we need to for the March 27th date. But for all intents and purposes, Manager Valdez, they definitely are sticking as closely to the budget as they can.
Thank you.
Thank you, John.
Thank you very much. And thank you, Manager Valdez. Anything else before we move to the next item, managers? Okay, not seeing or hearing anything. Thank you so much. We appreciate your hard work and dedication and this wonderful update. Thank you. All right.
Thank you, John, to you and your team. Thank you.
Yes, absolutely. The whole team and all the other people who I know are helping with the training. Thank you so much. Okay, we will now move to agenda item number 6, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health Enterprise Partners, and new development in Eastern Travis County. And I believe that Stephen Lamp will start us off with a short presentation. Mr. Lamp?
Yes, thank you, Madam Chair. I shall endeavor to share my screen.
Looking good so far. Whoops, lost you.
Lost me?
We lost you. No, you were sharing and now you're not.
We shall try again. Apologies for my technical skills or lack thereof.
No worries.
All right, what's going on here? Is that showing up?
Yes, it is.
All right, very good. Thank you. All right, this will be brief. This initially is an overview of where we are and what we're trying to accomplish in terms of governmental actions and regulatory actions for the downtown property. We need a rezoning of the downtown property, and we are also towards the final stages of negotiating an interlocal agreement with the city of Austin. For rezoning, we want to change from public to central business district. Public is great for Central Health to do something for its own use, but it's not particularly attractive to commercial developers. Any commercial developer that would ground lease or want to develop something there would have to change the zoning. So by doing what I'm going to call a macro or global zoning for the entire property, we are eliminating its step that costs time and effort for them. We also want to increase the floor air ratio from a default of 8:1 to 25:1. Very briefly, the floor air ratio is the proportion of building area to land area. So an 8:1 ratio, if you have 1,000 square feet, you can build 8,000 square feet of land. So obviously 25:1 is greater. On a practical basis, there's no immediate demand for 25:1, but we don't want to treat this as a one-off. This is a long-term, one-time rezoning effort. It has been a slow and, as far as I'm concerned, painful process. So we don't want to have to revisit this too often. So 20 years from now, if everybody wants to become Chicago, we have 25:1 and Central Health will be able to accommodate that. And the prior, I guess for the last 3 years, really, we had targeted a zoning overlay. Councilmember Kassar of the city had recommended now going to a planned unit development, so that is the current approach. Once we get rezoning going, which is a separate city process from the interlocal agreement, we need to relocate Red River Street, and that has now become an entitlement. The initial concept, candidly, was that, okay, we had Central Health had Hospital Drive, and we were sort of trading land to the city to straighten Red River Street. But the reality is now, if Central Health does not realign Red River Street, we will probably not advance to rezoning, or at least not to the order of magnitude that we would like. So several components. Initially, Central Health would convey land to the city for New Red River. Now, I don't know if you recall what was there before Block 164 started development was Hospital Drive. It still exists. It provides access to Block 168 garage, and that's the intersection at 15th Street. And I have a schematic on this, what I'll come back to later, but rather than go back and forth between screens, I think it'll be easier to finish this. Next, Central Health will fund a pro rata share via the 2033 fund of New Red River project costs. Now, this is to be considered a significant community benefit supporting the rezoning. Central Health also will front through 2033 New Red River project cost off Central Health property. So from 13th Street down to 12th Street, it makes sense to treat this all as one project, but that is city property, but Central Health is fronting this. And we will be, say, Central Health is to be reimbursed from the city by primarily a, for lack of a better term, sort of trade in land for the new construction cost. And fronting this in the ground lease that Central Health has with the 2033 fund, 2033 has the responsibility to design and construct this. So while Central Health will have to pay a pro rata share at start of construction, we have basically deferred approximately $1 million. Next, Central Health will grant city utility easements within a right-of-way that they will convey. That's more of a technicality. There are utilities in the existing road. Central Health does not want to assume responsibility for maintenance or operation of those, so we will be negotiating easements. Then we'll have, this is more of a technicality, and I'm not sure it's worth a whole lot, but Central Health and the city will agree in principle to coordinate future utility infrastructure. The city did just complete their RFP for the Health South building, and they have identified a potential developer there, which borders Block 165, the southern boundary of the downtown property. So there might be better opportunities to save effort in overall public funds across the different entities. City, in theory, will facilitate review of downtown future property development. I'm not quite sure what that means either. On the Red River project, which the city wants, it's only taken 14 months to get a building permit for that. So, but if we can save some time there, great. And then a minor win, but some reimbursement. Central Health has been paying Health South utilities via chilled water and oxygen and gas for quite a bit of time. So the city will be reimbursing us approximately $75,000 for that amount. And then there are other technical and performance issues in related terms. I won't spend a whole lot of time on this. After we get rezoning and after we get to interlocal, or towards accomplishing both of those, there are several actions that are required by the City of Austin. Now, obviously, we need the rezoning and the PUD approval, but in addition to the interlocal agreement overall, there are sub-steps that need to be taken. The vacation of the existing Red River requires city action. The city needs to approve the right-of-way valuation, and it's being conveyed to Central Health. The city needs to reprove new Red River project fees approval, or waiver, excuse me. It is a city action. There are multiple permits for temporary road closures, temporary sidewalk closures. It doesn't really make sense to include those or sort of have the city charge itself and then have those to refund those. We are also hoping that we obtain some waiver of future development fees for the downtown property. That is not a direct benefit to Central Health unless it should self-develop something, but it could be proved very valuable to potential developers and make the site more attractive. And we'll also need utility easements approved. After we get city approvals, we will need to go to the Travis County Commissioner's Court reviewing approvals because this is a real estate transaction as well. And with that, I will stop and keep quiet, take some questions. Nikel Mead, I believe, is on via phone tonight, and she can address any questions as well, potentially related to zoning or the ILA.
Mr. Giesel, are we ready to move to closed session?
Yes, I would say unless there's some specific questions that need to be asked.
Okay, then I'm going to go ahead and read this item plus items 7 and 9. Discuss agenda item number 6, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including in next steps in the redevelopment of the Central Health downtown campus, administrative offices, Central Health, enterprise partners, and new development in eastern Travis County. Agenda item 7, receive and discuss an update on the interlocal cooperation agreement between Central Health and the City of Austin for the realignment of Red River Street from 15th Street to 12th Street. And agenda item number 9, receive briefing from legal counsel and take appropriate action regarding Lehrman Wallace v. Travis County Healthcare District DBA Central Health, cause number D1GN20006645, Travis County District Court, closed paren. I announce that the board is convening in closed session to discuss agenda items 6 and 7 under Texas Government Code 551.072, deliberation regarding real property, and item number 9 under Texas Government Code section 551.071, consultation with attorney.
Madam Chair, I'm not going to be able to be, I'm going to have to leave right now. So I'm just.
All right. Thank you, Manager Jones. Appreciate your presence and have a good evening. Thank you. All right. So with that, members, everyone must leave this meeting. And Perla, what were we given a different link to go to?
Yes, everybody should have received the closed session meeting information.
Okay. So let's leave now and go to the closed session.
Madam Chair, you have 5 and council's on the line.
Wonderful. So we have a quorum back, correct? Wonderful. So we are back in open session. There was no action needed on any of those items. I am moving on to agenda item number 10, confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for Wednesday, December 16th, 2020 at 5:30 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and/or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I am ready to accept a motion for adjournment. I see Manager Valadez, yes?
I move we adjourn.
And a second by Manager Bell. So we have motion and a second. All in favor? Aye.
Aye.
Opposed, same sign. No abstaining. Thank you, members. Appreciate each and every
Happy
one.
Thanksgiving.
Yes, have a good evening. Thank you.